peer-reviewed original articles or book chapters. The national recognition is reflected by his fellowship of Australian Academy of Health and Medical Sciences (AAHMS) and appointment to the Australian Research Integrity Committee (ARIC). In addition, he has substantial managerial and leadership experience as executive and non-executive director of large healthcare and research organizations in Australia and overseas. Sir, welcome. It is my great pleasure to introduce today's moderator, our distinguished guest speaker, Professor Dr. UC Ghoshal, sir. Dr. UC Ghoshal, sir, is Senior Consultant, Gastroenterology, and Chief Luminal Gastroenterology and GI Motility at Apollo Institute of Gastrosciences and Liver Transplantation Hospitals, Kolkata. He is highly esteemed practitioner and medical researcher, bringing 4 decades of experience in field of gastroenterology, GI medicine, and more than 390 publications to his name. He is recipient of 34 awards, including Warren Marshall Award in 2019 of Asia Pacific Association of Gastroenterology (APAGE), and orations include 8 gold medals during his MBBS study. Currently in administrative position as founder member and president of Indian Neuro Gastroenterology and Motility Association, member of Rome Foundation, member of Rome 4 and 5 committees, director of Household Survey of Rome Global Epidemiology Study, president-elect of Indian Society of Gastroenterology and international advisory board member of Lancet Gastroenterology and Hepatology. Sir, welcome, sir. Today's program, Innowave, is a unique program that blends virtual and physical models. Our esteemed international speaker, Professor Dr. Gerald Hartman, will be delivering his session virtually from Australia. This session will be telecasted live at our national hub in Kolkata and will be moderated by Dr. Professor UC Ghoshal, sir. And this will be also relayed across 16 locations with 30 moderators in the field of gastroenterology. The list of locations, CME locations, and moderators respectively are at Vishakhapatnam, we have with us Dr. A. Shiva Prasad, who is DM gastroenterologist, Dr. A. S. Chalapati Rao, he is also DM gastrologist, and Dr. Nistala Srinivas sir, he is DM gastrologist. At Varanasi location, we have Professor Dr. S. K. Shukla, DM gastroenterology, and Dr. Hemant Gupta, again DM gastroenterology. At Vijayawada location, we have Dr. Rajesh Bathini, medical gastroenterology, DM gastroenterology, and Dr. Surendra Jain, he is consultant gastrointestinal laparoscopic bariatric surgery. At Chennai location, we have none other than Dr. V. Jayanti ma'am. She is MD DM consultant gastroenterologist, and Dr. B. S. Ramakrishna sir, who is director senior consultant medical gastroenterology Institute of Gastroenterology, Hepatobiliary Sciences Transplantation, SEAMS Hospital. At Bhopal location, we have Dr. Piyush Manoria, who is DM gastroenterology, and Dr. Gaurav Kohli. He is also a fellow in PGD HHMS, Siddhant Super Specialty Hospital in Bhopal. At Coimbatore location, we have A. Arul Selvan sir, who is DM gastroenterology, and Dr. P. Karthikeyan, who is again DM consultant gastroenterologist. At Madurai location, we have Dr. R. Ramani, who is DM consultant gastroenterologist, and PL Alagmanai. She is also DM gastroenterologist. At Jaipur locations, we have Sham Sundar Sharma, DM gastroenterology, Dr. Dinesh Agrawal, DM gastroenterology. At Hubli location, we have Dr. Sandeep Kumar, who is senior consultant at Advanced International Gastroenterologist. Dr. Nitish Ashok Gaurav, he is DNB Medical Gastroenterology. At Chandigarh location, we have Dr. Atul Sachdev, DM Gastroenterology, Dr. Manmohan Singh Bedi, who is DNB Gastroenterology. At Karimnagar, we have Dr. Vijay Mohan Reddy, who is senior consultant physician. Dr. C.H. Pranith, he is also DNB Medical Gastroenterology. At Nagpur location, we have Dr. Prashant Rate sir, who is MS General Surgery and Fellow, and Dr. Siddharth Dhande, who is consultant gastroenterologist. At Delhi location, we have Dr. Manish Paliwal, senior consultant DM gastroenterology. Agartala location, we have Dr. Minal Dev Burma, who is DNB gastroenterology. Kolkata location, we have Dr. Sujit Chaudhary sir, who is also a DM gastroenterology. At Ranchi location, we have Dr. Ravish Ranjan, who is DNB gastroenterology. At Patna locations, we have Dr. Ravikant Kumar, assistant professor gastroenterology, and Gyanendu Kumar, who is DM gastroenterology. In addition to these mega locations, We have 70 plus small centers throughout India. And now, without further ado, please join me in warmly welcoming Dr. Professor UC Ghoshal sir. And I now request him to kindly take this session forward. Sir, thank you so much for joining us, and please take the session ahead, sir.
Thank you and good evening, everyone. A good maybe evening or morning, Gerald. So I will try to do the context setting job. Now, these are my conflict of interest. What is chronic constipation? Chronic constipation, typically physicians start thinking if anybody says, I'm constipated. And then typically what physician ask is, how many times do you go to the toilet? The problem is, let me tell you, most patients who have constipation, they go to the toilet repeatedly because obviously they can't pass stool. That's why they are going repeatedly. And now you may think the fellow has diarrhea. He's going 5 times a day. So that's why don't ask how many times do you go to the toilet. Even if you ask that, next question is, what do you pass? What do you pass after going to the toilet? So this is what is called Bristol stool form chart. And this defines constipation. You can see this is hard stool, pebble-like. These are pebbles joined together, and this is dry stool with cracks. These are constipation defining stool. Why did they make this system? People have realized that if somebody has hard stool like this, his colon transit is slow. So there is a pathophysiological basis. When the colon does not move the stool forward,
Your slides
the
are not moving.
water, okay, can you correct this? The slides are not moving.
Yeah. Put it
Okay.
on slideshow.
So technical team, can you correct, or maybe I can say next and you move the slide. So now when the water is drawn, because the stool is lying in the colon for long, the stool become hard. And obviously hard stool are more difficult to pass than the soft stool. So by a simple question, what is the stool form that you normally pass? You can get an assessment of what is his colon transit. Is it slow transit or is it not slow transit? I'll talk about the test needed for that, but as a physician, simply ask what type of stool do you pass and get an idea whether the fellow has slow transit constipation or not. There are other symptoms, for example, straining, sensation of incomplete defecation, sensation of obstruction or blockage, maneuver to pass tools, for example, digital maneuver. These are other associated symptoms you must ask. If you read any trial on chronic constipation, they will talk about two terms. One term is SBM. What is SBM? SBM stands for spontaneous bowel movement. And then there is another term called CSBM. What is CSBM? Complete spontaneous bowel movement. So when we see a patient, we ask their SBM, we ask their CSBM. When we treat them, we ask their SBM and ask their CSBM. In fact, in every disease, you have a target. For example, in diabetes, you have a target that you want to have this blood sugar fasting this much or maybe HbA1c this much. Similarly, in chronic constipation, we have a target. One of the major target is stool form that is assessed by Bristol stool form chart. So all of you must have this stool chart available in your clinic. Second thing is, where I see a lot of patients where you write a diagnosis of IBS. And when I ask the patient says there is no pain, there is no discomfort. Still, a diagnosis of IBS has been written. Let me tell you, this is wrong. If somebody has chronic constipation, but no pain at all, and there is no organic disease, this will be called functional constipation. Functional constipation. On the other hand, when somebody has chronic constipation along with pain, particularly pain at least maybe once a week, more than 6 month duration, this is constipation predominant IBS. What is the difference? Difference is somebody who has constipation along with pain, he has a pathology which is causing hard stool, dry stool, but also he has visceral sensitivity sufficient enough to lead to pain. On the other hand, somebody who has functional constipation, he may not have visceral sensitivity sufficient enough to cause pain, but maybe he has reverse. That is visceral hyposensitivity or rectal hyposensitivity. Ask to this patient one question. Do you feel like having urge to pass stool? And if somebody says that he doesn't have urge to pass stool, there could be three reasons. One is stool is not reaching the rectum. That means he has slow colon transit. The second reason could be he has a megarectum, which can be even acquired. And third reason could be he has reduced sensitivity of rectum or rectal hyposensitivity. And you have to correct all those to treat this patient well. How common is chronic constipation in India? These are four epidemiological studies, which I will not talk about. But let me tell you, I'm sure you are getting a lot of patients with chronic constipation in your clinic. So, what is our treatment goal? Our treatment goal is improvement in the symptom, having at least, like in the West, they will say having at least three stool per week. In India, I would say having at least one stool a day, one stool a day. And the stools should be Bristol stool form 4 or 5. And finally, we want our patient to be satisfied. That means good quality of life. Now, this I will not deliberate now. This is Indian Neurogastroenterology Motility Association and ISG guideline for managing patient with chronic constipation. I'll deliberate this maybe later. Now, when somebody has constipation, what could be the reason? The reason is one, he may be having normal transit, 8 having constipation. Second could be he has slow transit. That means his colon doesn't move and that's why stool doesn't pass. And third could be fecal evacuation disorder. What is fecal evacuation disorder? Fecal evacuation disorder is like a achalasia of anal sphincter. When somebody has to pass stool, he has to increase his rectal pressure at least 1.5 times greater than the residual anal pressure. When somebody is passing stool, he is actually increasing the abdominal or rectal pressure and relaxing the pelvic floor. And when this ratio is more than 1.4, that means rectal pressure is 1.5 times greater than residual anal pressure, he will be able to pass stool. And let me tell you, these are the two Indian studies which showed that almost one third of the patient who come to our clinic have fecal evacuation disorder. Okay. Second is slow transit. How common is slow transit? This is a study by Sutep Gonlachanvit from Thailand, and it showed that almost you can see one third or little less have slow transit, but some patient can have combination of slow transit along with fecal evacuation disorder. Why is transit slow? Why is transit slow? Colon has a property of doing HAPC. What is HAPC? It is high amplitude propagated contraction. So HAPC means when colon contract and that contraction moves across the colon at least 30 centimeter, at least 30 centimeter. and it has an amplitude of contraction at least more than 30 millimeter of mercury. This is a normal HAPC. And the HAPCs are responsible for moving the stool forward. Somebody who has a poor HAPC, maybe muscle disease of the colon, maybe nerve disease of the colon. Now, these people will have slow transit constipation. And some people with even normal transit constipation may also have low HAPC. And as we go along, we'll describe to you what are the drugs that can increase HAPC. Now, remember one thing. You go to the West, there is a very strict referral system. The referral system is primary care. Until as the primary care doctor refers the patient to secondary care, he cannot jump. And until a secondary care doctor refers the patient to tertiary care, he cannot go to the tertiary care. This is a Western restrictive model. On the other hand, in India, according to our system, any patient can go to any doctor and no doctor can decline to see a patient. So therefore, our job is more tough than the people in the West. The reason is in the first go itself, I have to gain the confidence of the patient so that patient continues to come to me as a doctor. So therefore, in Indian consensus on chronic constipation, one of the statement was that should we follow a step-up approach, that means milder drug doesn't respond, go to little more effective drug doesn't respond, maybe in the initial stage even suggest lifestyle to the patient, now you lose the patient. Okay? So therefore, and if a patient get lost to us, we don't mind really speaking. But maybe he get lost from us and goes to somewhere else, which may not be the best. And ultimately, we want the patient to benefit the most. So if it is so, then we said top-down approach is better in India. Top-down means use most effective agent, then gradually come down and maintain on that agent. And this is one of the statement. Thank you so much. This was just to set the context so that our expert, Professor Gerald Holman from Australia, can elaborate on to you all pathophysiological and pharmacological aspect of chronic constipation. Professor Gerald, now the stage is yours. But before that, let me tell you, we are holding the annual Congress of Indian Neurogastroenterology and Motility Association on 30th and 31st August 2025 in Novotel, Kolkata. And Gerald has been kind enough to accept my invitation or our invitation to come to Calcutta. So therefore, Gerald is very important guest to us in next 2 months. Okay? Gerald, stage is yours.
Good evening, everybody, and thank you, Uday, for your brilliant introduction. My task is to drill slightly deeper and to share with you the connection between specific therapeutic interventions and the underlying pathophysiology. I have no specific conflicts of interest to share with you. The outlook of my presentation, I will start with the definitions, and you already have heard a good definition for chronic constipation, but you need to be aware that there are a number of different definitions, and the question is what definitions really serves your purpose in the clinical practice. Then we have the epidemiology, the pathophysiology. Uda already mentioned the various interventions we have. And one of the cornerstone almost certainly is lifestyle, while in the tertiary sector, it's probably not our first choice. It's worthwhile at least to consider this. And finally, I will talk about the pharmacotherapy with prucalopride. If we talk about constipation, it's important to look at, on the one hand, the epidemiology, but also at our knowledge base. And our knowledge base is quite nicely reflected by the publications which we can find in PubMed. And what I've done for today, I've plotted here the number of publications which use the keyword constipation. And I also have selected all papers who present trial data. And what you can see here is that there's a large number of publication and there's an increasing publication activity, but the number of trials, clinical trials that guide therapeutic decisions is still relatively low. Therefore, it's a well-known condition. We see lots of publications, but data which guide therapeutic decisions based upon clinical trials are very limited. Now let's move to the definitions. And the cornerstone for most clinical definitions in this entity of conditions which formerly were addressed as so-called functional gastrointestinal disorders, and now most of us use the term disorders of gut-brain interaction, as a Rome criteria. And Uday has been instrumental to refine and contribute to these definitions. And the most recent Rome 4 criteria for constipation are listed here. A patient who is being diagnosed with constipation must have 2 or more of the following symptoms: training during at least 25% of defecations, lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal obstruction in at least 25% of defecations. Some patients may report maneuvers to facilitate evacuation, and then the number of defecations should be fewer than 3 per week. A second criterion is loose stool are rarely present if you do not use laxative. And the third one, which is really important in this setting, patients should not meet the criteria for constipation dominant IBS. Therefore, a variety of criteria which a patient would meet. And if you see this long list, you may think it is quite complicated. But this is the current gold standard. And here is a study from the United States. But it's a global study which involved patients from a variety or people from a variety of countries. And in this study, 8% reported functional constipation, 4.6% IBS, and there's a significant number of patients with unspecified bowel disorders. And at least in the Western world, we increasingly see patients who have opioid-induced constipation. And I only just wanted to mention this because it's important to keep this in mind when you manage patients. Most of you are well aware that we have had various iterations of the Rome criteria. We will have Rome 5 in the very near future. And if you apply different Rome criteria, the prevalence of constipation is slightly different. Starting with Rome 1, in population-based studies, the prevalence was exceeding 15%, and the Rome 4 had only just 10%. Therefore, the definitions are important. And what is really important to keep in mind, that the more recent definitions are more restrictive, as reflected by lower prevalence rate, but at least in Western countries, it's still significant. Some of you may feel this Rome criteria are very complex, very difficult, so many criteria to keep in mind. And if I look at the literature and what is really practical, the Canadian Association of Gastroenterology has here a very simple, straightforward definition. Constipation is symptomatic with fewer than 3 stools per week, and they describe the stool consistency, as Uday already referred to, as lumpy and hard as one of the features. Therefore, however you coin it, It needs to be practical in the clinical setting. But constipation is more than just realizing that the number of bowel movements per week is reduced. Now the question, how do we do it in the real clinical setting? And this slide, I've included it to remind all of us that constipation can be a symptom of other systemic comorbidities. And this is a large database study. And what you see here is the number of bowel movements per week and the rate of mortality. And patients with a very low number of bowel movements statistically have an increased mortality. Therefore, patients who present with constipation may have comorbidities which are associated with an excess mortality. Therefore, keep in mind that constipation can be a symptom of other systemic underlying conditions which are important to consider before we just treat these patients. In relation to the clinical assessment, the Bristol Stool Scale is very simple, but it is very easy to use and can guide the assessment. The reason why it is important is that the visual appearance of the stool as captured with the Bristol Stool Scale correlates well with colonic transit tests. And multiple studies have shown this. Therefore, you can essentially expect or predict colonic transit time simply utilizing the Bristol Stool Scale. Therefore, utilizing this simple tool is very easy, very simple, but highly reliable in relation to transit times. In the clinical setting, we are not just treating transit time. Uday mentioned that there is ambiguity in relation to diagnosing IBS in patients who have a reduced number of bowel movements. And it's important to properly assess, quantify other symptoms. We here in Brisbane utilize SAGES, the Structured Assessment of Gastrointestinal Symptoms. This is a validated instrument which covers 22 different symptoms. It's very easy to use in the clinical setting. Patients typically complete it before they see the clinician. They actually get a text message with a link and then can complete it. And what I find extremely helpful are the two questions in your own words. What is your most important health concern or problem, and your second most important? And we did some studies, and we could demonstrate that using such a tool saves you several minutes in the consultation, because you can much easier identify the real problem of the patient. And this also captures symptoms associated with constipation, and this can greatly assist you to address the patient's needs. Therefore, if you assess patients who have the symptom constipation, it is important to assess more than just the number of bowel movements or the consistency of the stool, because the unmet need might be completely different. And if you properly ask the question, why are you here? What is your main concern? You will see that a significant proportion of these patients also articulate concerns such as cancer. Do I have cancer causing this problem? And then in these patients, you need to address these concerns appropriately. Now let's reflect a little bit about the different categories of constipation. And at a very high level, we can divide this into primary constipation and secondary constipation. So primary constipation are all patients who have symptoms of constipation due to a colonic or anorectal cause. Therefore, there's a muscular cause, there are neurologic causes which ultimately result in a slowed colonic transit. Secondary constipation are patients where we can identify a very specific cause for the symptoms. For example, pain medications, which I mentioned before, can cause constipation. And the same holds true for some antihypertensive drugs. Then on the other hand, we have systemic comorbidities or neurologic conditions. Parkinson is a very good example, which typically is associated with constipation. And patients who present with this type, with these comorbidities and having symptoms at the same time, we can label them as secondary constipation. Other patients have chronic idiopathic constipation, where it's not clear what actually is the cause of the symptoms. Important in the clinical setting that we do not simply stop with diagnosing constipation and initiating the most appropriate treatment, but it's important that we take the time in selected patient to exclude treatable causes. Some patients will require comprehensive diagnostic workup, and it's worthwhile to consider a colonoscopy in specific patients in our population, because there's always a statistical association between constipation and colorectal cancer. And now let's focus a little bit on the diagnostic tests which are available in the routine clinical setting to quantify function. And I have to provide you with a little bit guidance how important these tests are. These tests can provide information about the underlying physiologic disturbance, and they can demonstrate what is wrong with the function. But the question is, does it really make a difference with regard to the treatment? And there are tests which are time-consuming and costly, which provide great insights into the underlying pathophysiology. But the big question is, how much does this change the management? And I have to say, while some of the tests are very easy to use and other tests are time-consuming and invasive, the clinical benefit of the tests is typically not associated with the invasiveness or the resource requirement to do this. Let's have a look at the tests. The most simple test, and which is very useful in the setting because it's so simple, is a so-called Hinton test or colonic transit measures. Essentially, you feed patients for 6 days with radiopaque markers. Here, this is a commercially available model with different types, shapes. Patient takes them, and after 7 days, more than 50% should be excreted, and by assessing the position of the markers in projection of the abdominal cavity, you can define the transit time, and you can actually assess the regional transit time, therefore where do the markers are positioned. And this would be an example of a patient with slow transit constipation, and you can see different types of markers retained. On the other hand, we see occasionally patients who complain constipation, and when they undergo a marker or a transit test, you see that only a small number of markers is retained. Therefore, even though they have the symptom of constipations, they may actually have rapid transit. And this is a very simple test. We use this test routinely in patients where we are not sure whether really slow transit constipation is a problem we are facing. Slightly more sophisticated are colonic transit measurements utilizing scintigraphy. Here an example, it allows you to precisely quantify segmental transit times, and this test is time consuming and relatively expensive if you need to do it. For many years, colonic motility testing, therefore high-resolution manometry utilizing pressure transducer, have been very popular, at least in the research setting. And what you can see here is a catheter which is inserted endoscopically into the right colon. And if you do this, you can record pressure profiles over time. And depending on the type of measurement, you can have different topographic maps of contractile activities. And here's a example from Phil Dining from Flinders University, who showed the same type of patient, but just with different filters and different resolutions, how this can change the visualization of the spatial resolution of the contractions and the clusters of contractions as they move through the colon. Very impressive are these color-coded high amplitude propagating pressure waves, HAPW. This is a healthy subject, and just to give you an understanding, the centimeters on the scale show the distance to the anus. You see the contraction which moves through the entire colon, and there is a resistance barrier, which is the anorectal sphincter, which is responsible for the continence in these patients. And when a patient defecates, the critical thing is that the relaxation of the anorectal sphincter occurs in a timely fashion. In relation to the pathophysiology of patients with chronic constipation, we have learned that the number of high amplitude propagating contractions are significantly reduced in patients with constipation, and more specifically in patients with chronic idiopathic constipation. Therefore, restoring these contractile patterns could be seen as an appropriate way to normalize and treat chronic constipation. And how does this fit together? We have this high amplitude peristaltic contractions, and they are important for the colonic transit time. And colonic transit time is closely linked to the defecation pattern, the hardness of the stool, and essentially the stool scale when we measure it with the Bristol stool scale. Therefore, the number of contractions, the HAPC, relevant for colonic transit time, and this defines the severity of symptoms. Therefore, contractions, high amplitude peristaltic contractions, important factor for transit time. This defines whether constipation occurs, and this is ultimately relevant for the severity of symptoms. And what is important that most prescription agents do not have clear-cut effects on the peristaltic waves. They may increase the motility index by unspecific stimulation of contractions, but they do not necessarily induce this high pressure amplitude peristaltic contractions. I've put this slide in as a reminder that it's not only the colonic transit time and the high pressure contractions, but the pelvic floor function is equally important. And if we have outlet obstruction, the outlet obstruction can result in slow transit. Therefore, in selected patients, further testing is required. Here is an anorectal MRI, which shows different angles of the anorectal angle, and this can cause outlet obstruction and subsequently defecation disorders. Therefore, if we now look at a more sophisticated categorization of constipation, the first line of categorization is the transit time, and we have nearly 50% who have normal transit time, whereas nearly 50% have slow transit time. And again, 50% can have defectory disorders with normal transit, and the other group has defectory disorders with slow transit constipation. Therefore, slow transit constipation can be associated and potentially caused by defecation disorders. But what is important, regardless of the cause, 50% of all patients are dissatisfied with the currently available therapies. And the normal transit or slow transit is as markers of normal motor function do not really help us with regard to the therapeutic decision making. Now let's have a look at the available treatments. And we have a couple of treatment principles, and Uday mentions this. And for completeness, I would like to include lifestyle modifications, even though in the tertiary or quaternary setting, this typically is already exhausted by our colleagues in the primary care setting. But lifestyle modification, regular physical activity, and good bowel habits are important at the very baseline level. Patients need to be encouraged to have a routine with regard to their bowel movements. Dietary changes with a focus on sufficient fibers and fluid can be helpful. Some patients, if all this fails, will benefit from osmotic or stimulatory medications. And the next step are then targeted pharmacotherapies which stimulate secretion, or we use prokinetic agents, including prucalopride, and I would consider them as the treatment of choice in many of our patients. Just to show you the effect of lifestyle or fiber treatments, this is kiwi fruit and psyllium, and you see that indeed these treatments increase the number of bowel movement in healthy controls, patients with functional constipation, and patients with IBS-C. Therefore, they can be used. But in particular, in patients with IBS-C, in the clinical setting, I typically am not very convinced. Now let's focus a little bit on prucalopride. Prucalopride is a compound which we are aware for more than 2 decades. It's a so-called 5-HT4 receptor agonist. Therefore, this is a drug which stimulates this specific prokinetic receptor, and it's well characterized in relation to the effects on the motility or peristalsis of the small and large bowel. It's very clear, and this is consistent across all studies. It increases the frequency of bowel movements, and it has effects on symptoms of constipation, which are clearly better compared to the effects of simple laxatives. And this can be explained by the fact that prucalopride also has antinociceptive effects. Therefore, it increases sensory thresholds and makes the colon less sensitive to any kinds of mechanical stimulation. The safety profile is very good. Prucalopride has beneficial effects on the quality of life. And what is very important for a chronic condition like constipation, it is safe if it's being used for a prolonged period of time. I mentioned that prucalopride is known to mankind for more than 20 years. And this is actually one of the first published studies revealing details of the effects of subjects, in healthy subjects, of different doses of prucalopride. This study has been done at the Mayo Clinic by Michael Camilleri, and this study looked at the effect of prucalopride on gastric and small intestinal, as well as colonic transit. In healthy subjects, interestingly, the effects on small intestinal transit and gastric emptying are very limited. On the other hand, even in healthy subjects, there are significant changes within hours of administration of prucalopride, and this is shown in this study. Therefore, the different graphs show different time points for different doses, and it's evident that prucalopride, as compared to placebo, can accelerate the colonic transit within hours. Therefore, this is one of the first human studies demonstrating this very strong effect on colonic motility. Therefore, prucaloprides accelerates colonic transit and stimulates proximal colonic emptying. But interestingly, in healthy subject, it did not have a significant effect on gastric emptying or small bowel transit, at least in this relatively small pilot study. And at this stage, I think it's important to compare the effect of prucalopride against other interventions, such as PAG or a stimulatory laxative. And what you can see here is a motility index at different time points after administration of the different compounds. And what you can see is that prucalopride in green has a relatively rapid but sustained effect. And I mentioned before that one of the additional benefits compared to the normal laxative is that prucalopride has an anti-nociceptive effects. Therefore, this can help that in spite of the stimulation of motility, patients also have improved or no symptoms when they are treated with this compound. Now let's have a look at the placebo-controlled trial. And this is one of the study which has been done in recent years, a phase 3 trial, actually in men and not in females. And this study has one of this typical placebo parallel group design. Patients were treated for several weeks after randomization and a run-in period. And what you can see here, consistently during the entire study period, patient treated with active medication had a significant increase of the spontaneous complete bowel movement, SCBM, over time. And there's no reduction of the effect over time. Therefore, you have a sustained effect in patients who are treated with prucalopride. There's also a very nice systematic review that included all the prucalopride studies, and it is evident that prucalopride, and consistently in all the studies, provides benefits in patients with chronic constipation. Some more data on the very specific effects. Here, a study on the colonic transit time on the left side, and you can see that prucalopride at a dose of 2 and 4 milligram has significant change or results in significant change in the colonic transit time. And what I find is interesting that there is not a great deal of a difference between 2 and 4 milligram. Therefore, if I treat patients with prucalopride, I tend to take the lower dose initially. And overall, patients treated with prucalopride show a 50% response rate, which is really good for this kind of patients. If we compare prucalopride with PEG, it is evident that the number of propulsive contractions is significantly increased with prucalopride as compared to polyethylene glycol. Therefore, while the PEG causes an increase of the motility index, the propulsive contraction fronts, which are critical for the mass movements in the colon, are not affected in the same way by PEG. Therefore, clearly, prucalopride is the more effective treatment in these cohorts. Increase of frequency and a rapid and short time until the first bowel movement in patient treated with prucalopride. This slide summarizes a number of clinical trials comparing active medication with prucalopride versus placebo at different time points, 4 or 12 weeks. And what you can see here, that prucalopride actually is superior to placebo in essentially all of the studies and has a sustained effect. This results in improvement of a variety of symptoms. Uday mentioned that we need to differentiate patients who have constipations versus patients who have irritable bowel syndrome. And these studies, which are labeled as improvement of constipation symptoms, I would think some of these patients are actually patients with DGBI, but if you treat patients who may have constipation or may have constipation more in a setting of irritable bowel syndrome, you can rest assured that prucalopride is a treatment to improve symptoms as well, and there's a very consistent improvement. In the countries where prucalopride, it's always good to see that a specific compound is available in a large number of countries, and prucalopride is actually registered in a large number of countries, and it seems to be more widely available as compared to many other drugs which are available for the treatment of patients with constipation. Let me summarize my presentation. Prucalopride provides benefits to patients with chronic constipation who may have not experienced sufficient relief with lifestyle interventions or traditional laxatives. As a selective serotonin receptor antagonist, prucalopride has a very specific effect on colonic motility. It increases bowel movements and improves outcomes via these specific effects. And there are a large number of clinical studies which demonstrates a clinical efficacy, but equally demonstrates that this is a safe treatment which can be used for a prolonged period of times. And I would like to thank you for your attention.
Thank you, Gerald, for such an illuminating talk. So, as Gerald told you, that prucalopride is effective in patients with chronic constipation. But let us see whether this drug works elsewhere. That means other than colon, but in the rest of the GI tract. He did mention that in an initial small study, the prucalopride was found not to accelerate gastric emptying. But let us look into it further. So these are my conflict of interest. Now he referred to that prucalopride is a serotonin agonist. So serotonin is a key molecule in the GI tract. 5% of the body's serotonin is in brain. And if you see psychiatrists, they use a lot of agent to manipulate serotonin pathways in the brain to hasten or to decrease brain function as needed. But 95% of the serotonin is in the gut. On the other hand, gastroenterologists had very little avenues to manipulate gut serotonin. And if we have now, such as using prucalopride or earlier with cisapride, maybe we needed more knowledge. And that is what I'm going to talk about. Now, where from serotonin comes? It comes from tryptophan. We eat tryptophan in the diet. For example, typically a lot of cereal. Here I have shown a picture of maize. Maize is a good source of tryptophan. It is an amino acid. Now, this tryptophan is converted into serotonin, and you can see there are rate limiting enzymes. Now, the tryptophan that is converted into the serotonin outside the brain cannot go to the brain because there is a blood brain barrier and it cannot cross blood brain barrier. But dietary tryptophan can go to the brain because it is an amino acid. So therefore, we have another tryptophan hydrolase, which is called tryptophan hydrolase 2, which convert tryptophan into serotonin in the brain. And what does serotonin do in the brain? It is responsible for our emotion. It is responsible for our joy. Now, interestingly, this brain tryptophan going to serotonin can be converted into melatonin. And what does melatonin do? It is responsible for our sleep. So our sleep, our joy, our gut motility, gut secretion, bowel habit, all are interlinked through this serotonin pathway. And you must have seen a lot of your IBS patient or constipation patient tells you, Doctor, I don't sleep well. Why do they not sleep well? This has also been studied. They actually have a pathway in which serotonin, instead of going to melatonin pathway, goes to kynurenic acid pathway. So what is happening is instead of serotonin inside the brain making melatonin is going to make kynurenic acid, so they can't sleep. So this is very, very important that we are going to talk about. These are the serotonin receptors. So there are so many serotonin receptors. You can see there are primary receptors, which are 7, but there are secondary receptors in addition to that. Now, we gastroenterologists typically work with 5-HT1P receptor, 5-HT3 receptor, 5-HT4 receptor, and SART. What is SART? This is when serotonin is liberated into the synaptic cleft. Obviously, the serotonin, after it has done its work, has to be destroyed. That is true for any neurotransmitter. And the destruction happens by reuptake. Now, this is done by SART, and you have drugs which can manipulate this SART, therefore, reuptake is inhibited. And now you have increased concentration of serotonin in the synaptic cleft. All these basics I told you so that we can go further in the GI tract. Now, where all we want this serotonin manipulator to work? We want them to work in esophagus. We want them to work in stomach. We want them to work in small intestine. We want them to work in colon. But unfortunately, there are not many data outside colon. So Dr. Gerald told you a lot of studies which are in relation to colonic motility, prucalopride. Obviously, it is a serotonin agonist. But I will now talk about the serotonin agonist prucalopride and other parts of the GI tract. Now look at this. This is a study on which effect of prucalopride on distance and threshold and frequency of secondary peristalsis. That means whenever there is a reflux into our esophagus, so there is a distension of the esophagus. And the moment esophagus distend, what happens is esophagus initiates a secondary peristalsis, which pushes back the reflux content into the stomach. So this is a secondary peristalsis, which is responsible for esophageal clearance, typically esophageal acid clearance. Now, question is, this is a study where authors have used this secondary peristalsis study. So they have looked at how much volume is needed to initiate a secondary peristalsis in the esophagus when the patient is on placebo or on prucalopride, and they found at a lower volume of distending substance, there is a peristalsis if somebody is on prucalopride. So it means serotonin agonists such as prucalopride can initiate secondary peristalsis of esophagus to clear the reflux at a much lower volume. So if it is so, it should work in GRD. Let us look at. Here is the evidence. This is prucalopride reduces gastric acid exposure into the esophagus. These are GRD patients. They were treated with prucalopride and they looked at whether the esophageal acid exposure is reduced if somebody was on prucalopride compared to placebo, and they found a positive result. Also, because prucalopride actually stimulated gastric emptying. So therefore, this is another way to prevent reflux. Reflux happens when there is a dumping in the stomach. So the gastric pressure increases and there is a reflux to vent out the extra content to reduce intragastric pressure. So prucalopride work by initiating secondary peristalsis in the esophagus, and second, by clearing gastric content into the duodenum. Now, what were the adverse effects? The adverse effect were loose stool. If a patient is constipated, it is good to have loose stool. Headache is a peculiar adverse effect that many patients with on prucalopride they report. They can have nausea. They can have increased abdominal sound because it is increasing the motility of the small intestine. They can have abdominal pain, bloating, and increased appetite. And many of our clinic patients talk about, doctor, I have less appetite. So if somebody has increased appetite, it is rather good. Now, why do they have increased appetite following serotonin? This is very important to understand the gastric physiology. The stomach physiology differ depending upon whether you are eating liquid or solid. And I tell you, stomach anatomically is one organ, but physiologically there are two stomachs. One is proximal stomach and other is distal stomach. Proximal stomach is responsible for liquid emptying regulation. How? The moment we eat liquid like this, the gastric fundus relaxes. Gastric fundus relaxes. And this is mediated by vagus nerve. Somebody will ask me, how can vagus nerve relax an organ? I'll tell you later how it does. Now, this fundic relaxation is an accommodation of the stomach to have excess or extra liquid into the stomach. Those in whom fundus does not relax, what will happen? With a little liquid, they will feel very full. They may have nausea. They may vomit out. This is an accommodation defect of the stomach. Second is, let us look at the solid emptying. The moment we eat solid meal, actually pylorus closes. Now, why does pylorus closes? Pylorus doesn't want the solid content to go into the small bowel because small bowel wants pulverized content on which digestive enzyme can work. So pylorus closes and antrum has tremendous amount of movement, which is like a whirlpool movement, antral contraction. And that lead to a whirlpool phenomena. And we all know if there's a whirlpool phenomena, pulverized small particle will be in the center and the bigger particle with heavy weight in the periphery. And this sort of movement result into small particle of 1 to 2 centimeter to leak through the pylorus, though it is closed, it is open by 1 to 2 millimeter. So this is an effect of vagus nerve again. So in the distal stomach, vagus is causing contraction, pylorus opening. In the proximal stomach, vagus is causing relaxation and gastric accommodation. Now, if somebody has functional dyspepsia or gastroparesis, that means the stomach is paralyzed or stomach is not really normal, they have a poor fundic relaxation. This fundic relaxation becomes defective. And if you want studies on this, look at this. This is a study where healthy people were allowed to drink ad libitum and the functional dyspepsia or postprandial distress syndrome type were allowed to sort of drink ad libitum. And what did they find? They found that patient of functional dyspepsia who have postprandial fullness, they could not accommodate lot of water in the stomach. Okay. So this is another study from Spain where the same experiment was done, and you can see that there was similar observation. That means they have an poor accommodation. And these are the two studies that we have done in Apollo in last 1.5 years. The first study is we took gastroparesis patient, we took functional dyspepsia patient, and we gave them water load to study how much water they can accommodate. Second, we did their electrogastrography to see what is happening to the electrical signal of the stomach when we are pouring water into the stomach. And what we found, the first study is a smaller number of patients, about 80, and the second study is in a large number of patients, more than 600. And we found that these patients who has functional dyspepsia, postprandial distress syndrome type, they have an accommodation defect of the stomach. They cannot accommodate extra water, particularly those who have nausea as a predominant symptom or some vomiting. Now, how does it happen? How does fundic relaxation occur in response to stimulation of vagus? We all know that in neural pathway, the first order neuron, the synapse is all cholinergic. But in the third order neuron, the motor end plate where the nerve is ending into the muscle, there even the neurons which are cholinergic proximally may be nitrinergic, may be VIPergic, or maybe dopaminergic. And in fundus, interestingly, nature has given more nitrinergic neuron. On the other, in antrum, it is more cholinergic neuron. So what is happening is that's why same vagus, which is getting stimulated, in fundus, it is causing relaxation through nitric oxide pathway. In antrum, it is causing contraction. And can we manipulate it with drug? Yes, we can. Now, this is an intrauterine manometry signal that we recorded while I was in SGPGI. We had the machine there. Currently, we don't have here. Now, look at this. We can manipulate fundic relaxation. We can manipulate using buspirone. We can manipulate using acotiamide. We can manipulate even using procalopride. So I'll skip this slide. This is a prokinetic. This is felcitrag, which is a 5-HT4 agonist. And the other one is procalopride, which is again 5-HT agonist. So 5-HT agonist increases gastric emptying. Okay? So Dr. Gerald told you that in one study, it did not increase emptying in healthy subject. This is because in healthy subject, already emptying is maximum. So drug did not work. But in disease patient, actually it caused increased emptying. This is a study from Yantak group from Belgium. What they did is they gave procalopride and placebo to patients with functional dyspepsia. And then now they looked at accommodation function of the stomach by giving them water as much as they can drink. And you can see those who were on placebo, they were not able to tolerate a lot of water, but those who were on procalopride could tolerate. Okay? So therefore, by procalopride, we can really empty the stomach and we can somewhat relax the fundus of the stomach. This is the extension of the same study. Why I'm talking about this? We are talking about this because rarely you get patient with pure symptoms of constipation. Many of you know that they come with overlap. They come with constipation plus epigastric discomfort. They come with constipation plus belching. That means they do not have only colonic motility problem. They have colonic plus upper GI motility problem. And the overlap is commoner. Look at this. This is an epidemiological study that we did in Uttar Pradesh, where I was in SGPGI. And it shows pure colonic problem are rare. More often they have overlap with other proximal gut problem. And gastroparesis patient, they not only have stomach problem, they have also constipation. Why do they have constipation? This is because if the stomach doesn't empty, the food doesn't go down and therefore stool doesn't get formed. Second is many of these patients with gastroparesis, it could be caused by drug. For example, somebody is an opiate addict. Now, this fellow will have gastroparesis because of opiate. He will have slow colon transit as well. Many of them have diffuse GI motility disorder because we all know the nervous system, enteric nervous system, when it is affected, it doesn't selectively affect one part of the gut, but it affects most part of the gut. And next is the concept of cologastric break. What is cologastric break? Cologastric break is when the colon does not empty. Nature has given us a system so that it gives a break to the proximal gut motility. It tells that I'm already full. Don't pour more food from proximal end. So that is cologastric break. And there have been ample number of studies to prove this. This is a very interesting study. Now, there was a study which was published in Lancet. Healthy volunteer, they underwent assessment of gastric emptying. Then they were asked to hold their stool for 7 days voluntarily. And then they underwent gastric emptying again. And they found gastric emptying got delayed if he did not pass stool. This is concept of cologastric break. This is another study where patient with severe constipation, they underwent colectomy. Before colectomy, gastric emptying was studied. After colectomy, gastric emptying was studied. And they found if you remove the colon and improve his constipation, his gastric emptying increase. Makes sense. Makes sense. Because if the rectum is not emptying, why should stomach get more food from the proximal end? So therefore, overlap pathophysiologically should be commoner than what maybe Rome believed or the world believed. So we have to give relief to the patient with a pan-GI prokinetic. This is a very interesting patient from our lab. This is a patient who has slow transit constipation. And we did a marker study. This is, Gerald was referring to markers. India has now marker. This is approved by Drug Controller General of India, and I hold the patent for 20 years. Now, this marker is called Transimark. Now, we did a colon transit in a patient of constipation. Look where the markers are retained. The markers are retained all in the stomach. That means this patient not only has constipation due to slow colon transit, but has gastroparesis associated, and we could uncover it with the marker study. So therefore, principle of the treatment of all these patients who talks about gas, talks about motility problem is evacuate the bowel. If you evacuate the bowel, proximal gut problem will be relieved. And this is what we have spoken in this Asia-Pacific guideline for managing functional dyspepsia overlapping with other gastrointestinal disorder. So all these GI motility disorder or DGBI, disorder of gut-brain interaction, they more often overlap than they being a single disorder. And to improve their outcome, actually, you have to use drugs which work in different parts of the bowel. This slide, Gerald already showed. I'll not show it again. But this is a very important study. This is an Asian study that we did under Asian Neurogastroenterology Motility Association. 323 patients of DGBI. Those days, they were called functional GI disorder. We asked them how satisfied they were with treatment received from the gastroenterologist or physician. And let me tell you, a good proportion were dissatisfied. We checked which DGBI type were most dissatisfied. Now we found constipation and IBS-C were most dissatisfied. We looked at what treatment was received them earlier. when they came to us to visit us, and we found a lot of them received only PPI. Why? Because they spoke about their dyspeptic symptom. They did not utter their constipation symptom. Maybe in a busy clinic, doctor did not have time to do a wholesome evaluation like Gerald was talking about using a SAGIS questionnaire. So therefore, whatever symptom they uttered to the doctor, for that he received PPI, and that is the reason why they were dissatisfied. So, therefore, I would suggest that if a patient has overlap disorder, give a drug which is a pan-GI prokinetic, maybe like procalopride. In earlier days, cisapride was a very good drug. It was another pan-GI prokinetic, but we lost cisapride because of its side effect. Now, this is Indian constipation consensus, which was published even before procalopride probably was introduced in the country, and you can see the place of procalopride. So top-down approach, already I referred to, we want to treat our patient with a top-down approach to gain their confidence. And if there's an overlap disorder, which is more common, treat using a pan-GI prokinetic. Thank you so much. Greeting from our team. And I must again tell you, we are doing Indian Neurogastroenterology Motility Association Annual Congress on 30th, 31st August in Calcutta at Novotel Hotel. You may be interested. Thank you so much. So now we'll open this for question answer, both from Gerald or myself. Thank you so much.
Go to Zoom.
Go first.
Hello.
Thank you so much. We have all the regional moderators online from various locations. I request any queries now. FAQ session has started. We have all the faculties here. So
From Chennai, yeah, from Chennai. Can I speak from Chennai? Dr. Jayanti here.
Yes, ma'am, please.
Yeah, so there's a question from one of the colleagues here. Can we use prucalopride in normal transit constipation? If yes, what is the difference in its action, I think? So can we use prucalopride in normal transit constipation? Dr. Holtman?
One of the primary effects of prucalopride is to accelerate colonic transit. If a patient has normal transit, it does not necessarily rule out that he will benefit from prucalopride, because more accelerated colonic transit will change the water content of the stool. Therefore, I personally would just try it. It's an easy approach, and there's a still 50% likelihood that the patient will respond.
Thank you. One other question. What time would you administer prucalopride?
Dr. Jayanti, can you hear me?
Yeah, we can hear you.
I think what Professor Gerald said, I agree. In addition, I will refer to a study which was presented by Gerald as well as me. This was published in American Journal of Gastroenterology, where they use procalopride in every constipation, but they subdivided this patient into normal transit, mildly slow transit, and severely slow transit. And what they found is procalopride worked best in mild to moderate slow transit constipation. It worked even in normal transit with a lesser predictability. And in the very severely slow transit, it did not work. It really makes sense. That means there is a gradient of response. If somebody has a normal transit, the response may be less than if somebody has mild to moderate slow transit. But if it is a severely slow transit, maybe it is so bad a state that medical therapy like procalopride may not work.
Thank you, Uday. There's a question direct to you. We'll just finish off with Chennai. Can we use prucalopride in GRD? This is by Dr. Vincent Churchill from Chennai, Dr. Vincent. Prucalopride in GRD.
Yeah, so this is the data that I gave you. Both experimental studies showed secondary peristalsis was better those who received procalopride. Also, it showed that in GRD patient it could reduce esophageal acid exposure and improve gastric emptying. Therefore, you can. But I would say this is not a primary drug for GERD. If you
Thank you.
look at any algorithm, nobody will recommend procalopride for GERD. So
Sure.
therefore, where will I use it? I will use where there are, let us say, constipation along with upper gut symptom, including GERD. This is an overlap disorder. My primary aim is to treat constipation, but I know secondarily there will be benefit of GERD as well, along with another drug such as PPI.
Okay, last question to Dr. Holtman. What is the timing when prucalopride should be given? Evening, night, or morning? Because I understand it acts within 4 to 6 hours.
Yeah, I think it is not necessary to prescribe morning or evening. What is critical that the patient takes it really regularly at the same time of the day. Therefore, not one day a morning dose, the other day the evening dose. The bowel movements will occur after a time period or an interval after the medication. And the objective here is to synchronize bowel movement and ensure that it becomes regular. Therefore, medication should be regular, but not necessarily morning or evening.
Thank you so much. Then we will. I'll be moderating. Few FAQs where for each centers there are 2 questions. If are there, can discuss so that each centers will have a sufficient time to get all the queries answered. So I'll name one by one so that there should not be any chaos. So from Delhi, I think Dr. Manish Paliwal sir have some questions. Sir, over to you.
Yeah. So there's a query that what is the dose of prucalopride to initiate in chronic constipation? From Professor Uday Ghoshal.
So the recommended dose is below 65 years of age, you give 2 milligram per day. After the age of 65 year, you give 1 milligram. If you look at dose finding studies, it used even higher dose, for example, 4 milligram. But that is what is not typically recommended by regulatory agencies. So therefore, I'll not prescribe that dose. And also, Gerald told you that when in a study 4 milligram was compared with 2 milligram, there was no additional benefit of 4 milligram. Also, remember what is the problem of higher dose of procalopride. There has been studies where they looked at cardio safety of procalopride in relation to dose. Procalopride is like cisapride, but the cisapride was less selective. It affected human GOGO receptor gene, which is responsible for mediation of cardiotoxicity. Procalopride doesn't affect it when it is in small dose. But if you give big dose, then it loses its selectivity. So therefore, I would not recommend more than 2 milligram per day.
There's another question for Dr. Gerald. Now, what are the practical points when would you like to switch from one drug, say plecanide, eloxabixibat, bisacodyl, PEG, or lactulose, and prucalopride? So how would you take your patient through it depending on the response?
Okay. I mean, if many patients with classic laxatives experience experience abdominal pain symptoms because they don't have the antinociceptive effect. Therefore, this would be if you give a laxative, the laxative works, but causes abdominal pain, discomfort, this would be a point for me to switch to prucalopride. And it's always a choice if there's insufficient response to therapy.
And how would you define that insufficient response to therapy, just for the benefit of the audience?
Very clearly defined by the symptoms of the patients. I would clearly ask how is the number of bowel movements being changed. We would use the Sargis questionnaire, which a patient completes before I see him, therefore that we try to embed into the assessment this patient-reported outcome measures.
So I would like to ask Professor Ghoshal also. In India or in the Asian, we have a different way of stool habit. Our stool habit is much different from the West. So how would you prefer, sir?
Very good question. Let me tell you. In the West, they will be satisfied with 3 stool per day. And obviously, stool form should be maybe Bristol form 3 or 4. But unfortunately or fortunately in India, our patient wants little more. So I would say at least 5 to 6 stools per week and maybe Bristol stool form 4 to 5. But in addition, patient satisfaction overall is important. It is not just how many stools. So if the patient feels better, then this is our outcome measure.
I mean, there's frequently this feeling of incomplete evacuation. Therefore, it's not just the stool consistency. And if you have a medication that achieves that the patient has this perception of a satisfying, as Uday said, or complete evacuation, you have achieved your objective.
We'll move to the other center.
Yeah, thank you so much, sir, for asking these questions. I'll move to the next center, which is Nagpur. Can I request Mr.
Hello.
Prashant?
Yeah.
Prashant Rade, Mr.
Hello.
Siddharth Dande.
Thank you. We have one question from the audience here. What is the role of prucalopride in neurological disorders, especially in the post-operative phase when there is, for example, decompression of nerves during disectomy or any neurological surgery has been performed? So in the post-operative phase and in the neurological scenario, where does prucalopride stand? Dr. Uday, sir.
You see, in neurological degenerative diseases, constipation is common, and often it is a slow transit constipation. So prucalopride works there, provided you are also giving the primary therapy for neurological disease, such as for Parkinsonism, appropriate medicine, and Parkinsonism control. As far as postoperative state is concerned, there has been a few studies for postoperative ideas. And they showed that it works in postoperative ideas as well. But in that situation, you may have a better therapy rather than giving prucalopride. You need more effective therapy. Many a time you need parenteral therapy rather than oral therapy.
Yeah, one more question from Nagpur. There is a question from audience. What is the incidence of serotonin syndrome with the use of procalamine? I think they must be asking about the toxicity of the procalamide, or what is it?
You see, if you give serotonin agonist, there is an entity called serotonin syndrome, typically associated with flushing, tachycardia, anxiety, and all these. But the serotonin syndrome does not generally occur if you give only prucalopride in the recommended doses. But if you are using multiple drugs, which are serotonergic agonists, you can have serotonin syndrome. So therefore, it is better that you look at the drug interaction, see how many drugs which are serotonergic agonists that you are using. Better avoid multiple serotonergic agonists in one patient.
Sir, in the Indian condition, the diet is very bulky and the stool is also very bulky. So the incidence of the redundant colon, redundant sigmoid, or even the redundant transverse colon is also high. So how does this procalamide help in such colon?
Oh, this is what we are telling you, that these are what you radiologically see as redundant colon. It is often associated with slow transit, and procalopride works in moderately slow transit, doesn't really work in severely slow transit patient.
Yeah.
Any
So
Hello.
after centers
This-
dice will be open for
Sir,
the entire
one more
30.
question, please. This is just a practical question. That what is the endpoint of stopping procalopride? How do we stop it? Like if the patient is taking 2 mg and having complete evacuation and subjective improvement is there, do we de-escalate the dose to 1 mg or do we suddenly stop it?
Yeah, you see that there has been studies on this, how long procalopride effect lasts. And these studies have been done up to 3 to 4 years. And they found there is a loss of response with time in some patients, not in all, but only in some. When loss of response occur, if you are using a small dose, you can increase the dose. But typically we do not write more than 2 milligram. In that case, in case of loss of response, we can add another pharmacological agent rather than procalopride. But if your patient is doing too well, it is good to de-escalate and see whether the patient response is lasting or persisting. De-escalation means you may give either 1 milligram, from 2 milligram you reduce to 1 milligram, or you can go to on demand. But most patient has loss of response rather than very great response, and you can reduce their dose. Often it is reverse. You have to increase their dose or add another agent.
Thank you so much, sir. Moving to the next center, because we have limited time. So thank you so
This
much.
is from
We
Hubli.
invite Patna region, Patna team.
Yes, Dr. Bimal from Patna. I have a question to Professor Gerald. Your Rome criteria to diagnose constipation. So how can you quantify symptoms 25%, 25%?
My response with good question. Next question, please. This is one of the weaknesses of the Rome criteria, which are very complex. And I try to hint that we need much more practical approaches. Rome criteria are good for clinical trials when you define inclusion criteria to have consistent group of patients. But in the routine clinical setting, the Canadian or most likely the Indian criteria are much better.
Okay, thank you.
This is from Hubli. So there is a question
Thank you,
from
sir.
audience. There is a question from audience. This is from Hubli, Karnataka. So this is a question for Professor Uday Ghoshal, sir. Role of procalopride in children below 16 years. And pregnancy also.
Difficult question for me, you know, why I'm not a pediatrician. Maybe we wish there is a pediatrician in the room. Is there any pediatrician in the room? No. I think you better ask to a pediatrician. I may not be the best person to answer.
What is the experience of pedi?
Sir, what is your experience?
Any studies are there?
Okay, thank you so
Any
much.
studies? What is your experience? Yes,
Thank you
sir.
so much for the questions. From Madurai region, I would like to
There is
invite
one more question actually.
Dr. R. Ramani sir and Dr. PL madam to join the dice and ask if any questions are there.
Not
From Madurai.
So one more question from Hubli.
From Madurai, shall we finish?
No, it's not.
Yeah,
Does
ma'am.
procalopride cause any gut dysbiosis? And what's your
Sir,
experience in management?
Sir, we will
of
come to you. Sir, we will
this
come to you.
constipation?
Sir, we will come to you after all questions are taken.
Sure.
So we have
Yeah.
one question.
Dr.
So
PL, ma'am, please.
is there any trial comparing procalopride versus bisacodyl? because many of our patients are much happy with bisacodyl. So we wonder whether we really ask them to stop and switch over to prucalopride or for any safety measure. Is there any study to comparing these two drugs?
So, to the best of my knowledge, there has been no head-to-head trial comparing prucalopride and bisacodyl. There is a study on more than 247 patients from multiple UK centers, which showed that bisacodyl is associated with a good response among constipation patient compared to placebo. So bisacodyl is effective. It has been substantiated by a multicentric UK studies on more than 250 patients. It is exact number is 247, not more than 250. But there is no head-to-head trial comparing with prucalopride. In my experience, bisacodyl is a stronger drug than prucalopride. So I will give it as a rescue therapy or a SOS therapy. I'll not give it as a primary therapy. Why? Because bisacodyl is very strong and muscle pain, abdominal pain is a common side effect, which may not be there so much with prucalopride.
Because prucalopride has this antinociceptive effect, which is not with bisacodyl, which is just prokinetic, stimulatory, irritant.
Whenever there is a need for second laxative when you give prucalopride, you were telling that after a few years there may be a decreased response.
And your volume is little bit low. Can
yeah,
tech
okay.
person can
I'll
check,
make
you
it
know,
louder.
the
I'll make it
sound
louder.
there
Is
from
it
Madurai.
audible
Meanwhile,
now?
we will
No,
move to the other team members. Since your volume is low, we will come back to Madurai. Hubli team,
Hello?
you were having some question. Dr.
This
Sandeep
is from Rajiv.
sir.
Hello?
Hubli team.
Hello.
This is
Am I
Yeah,
audible?
please.
Yeah. So,
Yeah, sir, you are audible.
any experience in pregnancy, sir, regarding prucalopride? Because lots of pregnant female, they come with the issue of constipation these days.
I would say prucalopride is not a safe drug in pregnancy. So there are so many other choices which are much safer. Use those. Do not use prucalopride.
And does it any incidence of
Gerald, do you have any opinion on this? He is asking prucalopride and pregnancy.
I would be very cautious to use prucalopride because its systemic effects. There are other interventions which are just limited to the lumen of the gut, like PAG. In pregnancy, I would try to avoid it, but not because there are specific side effects known, just as a principle.
and does it cause any gut dysbiosis, sir?
Yes.
It's a question whether prucalopride causes dysbiosis or whether dysbiosis causes constipation. Because there's now emerging data that dysbiosis or specific difference or specific colonizations actually can play a role in the manifestation of slow transit.
You are asking dysbiosis. You see that if somebody has methanogen overgrowth, about 1/3 people in the community, they have excess methane producing bacteria in the gut. And if somebody has methanogen overgrowth, this causes slow transit constipation because methane depletes serotonin. And there has been still now 3 studies in the world, 2 from Mark Pimentel from US and 1 from our group from India, which shows that if you reduce methane by antibiotic, you can improve constipation. But there is a subsequent a study from Mark Pimentel, where he showed after successful treatment with antibiotic, if you give prokinetic, recurrence of methanogen overgrowth is delayed, and that is the way how constipation may be prevented.
Thank you, sir, for your questions. Now we will be moving to the Coimbatore region. We have Dr. P. Karthikeyan sir and Dr. V. Arun Sevan sir. Please join the
Yeah.
dice and ask your question, sir.
Yeah, this is from Coimbatore. I'm Dr. Arul Silvan. I have one question from Dr. Gerald. Is any role of combination therapy? Is any role of combination with prochloride with PEG or prochloride with the chloride channel activators? Is any study on that? Combination therapy for chronic.
I'm not aware of any specific studies who have tried the combination, but I think it's a not unreasonable approach if nothing else helps in very complex patients.
This is to Dr. Uday, sir. Is there any CNS side effect with prochloride like levosulfide causing extrapyramidal symptom? Like cause any other CNS side effect?
I mean, in the clinical studies, there are CNS side effects, but the rate is not significantly higher to the rate in placebo-treated patients.
Sir, this is a question for Dr. Uday, sir. Is there any advantage of splitting the dose of prochloride, 1 milligram in the morning and 1 milligram in the evening? And also, is there any advantage of combination of prochloride along with lubiprostone, secretagogue, something like lubiprostone or something?
Uday, do you want to take it?
Yeah. I think it doesn't make really great sense to give 1 milligram morning, 1 milligram evening, because you want your patient to have one stool a day. So therefore, I'll give all the medicine at one time, as Gerald rightly said, whatever patient choice is or doctor's choice is. At least I personally prefer giving early in the morning, immediately after getting up from the bed. That is my practice. Now, about combination, yes, there has been some studies in which prochloride has been combined with elobixibat or other agent, but that is as needed. Like if your patient is not responding to one drug, such as prochloride, and you know that you don't want to increase the dose further, you have already given maximum dose, you can use another drug in addition to prochloride.
Thank you, sir, for your guidance and suggestions for these questions. Can we move to the next region, which is Chandigarh? Dr. Atul Sachdev sir and Dr. Manmohan Singh Bedi sir, can you please come to the dais if you have any question? Chandigarh? Yeah, sir, over to you. Sir, you are not audible.
Am I audible now? Yeah, okay. But let me just start by complimenting both the speakers. We had an excellent session. Most of the queries, I guess, have been answered, but a couple of points. In fact, it just, my colleague here wanted to ask, will it work for acute pseudo-obstruction? You have an issue, is there any data to show that prucalopride actually works for pseudo-obstruction? Maybe Uday or Dr. Gerald can answer that.
I mean, chronic pseudo-obstruction is clearly a very rare condition. I'm not aware of the prospective randomized trial, but if I see this kind of patient, prucalopride is clearly one of the compounds which I would try as part of the spectrum of drugs which you can test, whether it's somatostatin. And now look, it's a very difficult situation, and it's a trial and error approach, and 5-HT4 receptor agonist potentially could help.
Well, thank you. Another question is, has there been any improvement in, say, mood? You know, Uday did show us the mechanism of action of prucalopride and the good effect it has on serotonin. Has there been any mood elevation? I mean, are you aware of improvement in behavior by use of prucalopride?
Can you repeat the question? We could not really.
Any effect on central behavior. There are disturbances. Basically, some of them are depressed. Some of them have low mood. Has there been any improvement in mood with the use of prucalopride? Has anybody
So very
studied
good
that?
question. So very good question. I tell you, at least not any study to the best of my knowledge did not document that. But my experience says when you treat this patient effectively and they really have spontaneous, complete spontaneous bowel movement, their mood improves. So therefore, looking at the mood and effect of procalopride, there has been studies on quality of life in which there are questions related to mood, but primarily looking at the mood and CNS, there has not been any great study to the best of my knowledge. But my experience is when you give CSBM to them, good CSBM, they really become happy and their mood improves. Many patients who have sleep disturbance, I actually add melatonin to it because melatonin is another serotonergic agent and this works for their sleep.
Thank you so much, sir, for
Thank you.
sharing your.
Thank you. Thank you.
Now we will be moving to the Vizag team. We have Dr. A.V. Shiva Prasad, Dr. A. Shalapati Rao, and Dr. Nistala Srinivas. Can you please come on the dais?
Gaurav, sorry to interrupt. We have some online questions also. If once we are done with the mega locations, can we take online questions?
Thank you. We have a couple of questions here. Number one, in patients with opioid-induced constipation, would you expect prucalopride also to be equally effective, or is there something else? I mean, are there any trials to show the effectiveness in opioid-induced constipation, for one?
Yeah, you see, opioid-induced constipation is often severe. So prucalopride alone may not work. There has been a study from southern part of India on patients who were on chemotherapeutic agent along with narcotic analgesic and having constipation. And this study was primarily with Sena. And it showed Sena, which is another stimulator of HAPC, worked in them. Prucalopride as a single agent, I'm not aware of any great study, high quality study. But since these patients also have slow transit, it may work particularly if it is not a severe slow transit constipation.
The second question is, we've been using prucalopride for quite some time and quite satisfied with it. And recently now we've got elobixibat and plecanatide also available. Can you tell us how exactly the new drugs would be perform in comparison with our already existing experience with prucalopride? Is there a kind of profile of patients for which one drug would suit over the other?
Yeah, I'll tell you, since India is getting a lot of such medicine which are higher level in the management of constipation, it is important to choose among them. Prucalopride is an effective drug, but it doesn't work when somebody has severe slow transit constipation, which is borne by data. On the other hand, look at elobixibat. It is also a strong agent. Only thing is side effect of elobixibat is abdominal pain. So if somebody has constipation and severe abdominal pain or moderate abdominal pain, you are referring to IBS-C. Now IBS-C, I'll prefer prucalopride over elobixibat because I do not want pain to increase. Second is if a patient on elobixibat gets severe pain or significant pain, I'll reduce the dose. If still pain continues, I'll switch from elobixibat to prucalopride. Now, when I switch from prucalopride to elobixibat is when prucalopride has failed. And I've seen in many patients, particularly those who are severe, prucalopride plus elobixibat works better than either drug alone. And in fact, there has been studies on this combination of prucalopride and elobixibat. They work similarly. Elobixibat increases gut colon transit, also prucalopride does. But in addition, elobixibat actually increases rectal sensitivity. Now, third is if somebody has a lot of metabolic problem, hyperlipidemia, dyslipidemia, diabetes, there has been studies with ilobixabat which may improve at least lipid profile. So looking at the comorbidity, looking at the severity, looking at the response and then non-response, you can switch from one drug to another drug, but these are all good drugs.
Thank you, sir, for sharing your questions. We will be moving
Question to
to
Professor Ghoshal, please. Sir, in the clinical practice, do you recommend doing colon transit studies before using prochloropride because this mainly increases the motility? And second, what would be your choice in patients with Parkinson's who are very resistant to constipation? They're not responding to most of the drugs.
Yeah, I think Parkinson patient, I already told in response to another person question. I think, therefore, I would not talk about it because of shortage of time. Yes, we do colon transit. We do colon transit because it helps me to understand my patient better. But let me tell you, I get a lot of tertiary level patient from different parts of the country. And in tertiary level practice, I would like to know my patient completely. If somebody has fecal evacuation disorder plus slow transit, I'll give him biofeedback plus this drug which improve transit. On the other hand, if I have not investigated them, then non-response will be higher. So that is the reason I would say I will test transit before choosing a therapy, particularly in tertiary level refractory patient.
Thank you, sir, for your questions. Moving to the Bhopal region, we have Dr. Piyush Manoria and Dr. Gaurav Kohli to share their queries.
Yeah, sir, is Pucalopride safe in patients with renal impairment?
Question to whom?
Ghoshal, sir.
Ghoshal, sir. The question is Pucalopride is safe in CKD patient, renal impairment patient?
Yeah, you can use smaller dose.
And some patients have diarrhea and headache. So it is a good strategy to start with 1 and then increase the dose to 2 mg.
Since diarrhea and headache doesn't occur often, I start with 2 mg and then reduce rather than other way around.
Okay, thank you.
Sir, we have last 3 questions from the audience, last 3 questions. Dr. Pradeep Gore will be sharing. That's all. After that, we will be closing it. Dr. Pradeep Gore, can you please share the questions came from the online audience?
Hello. Can I ask 2 questions from
thank you so
Agartala?
much.
From Agartala? Can we have 2 questions from Agartala here?
Yeah, we
Yeah,
can.
yeah, yeah.
We can.
Am I
Okay.
audible? Yeah. So
Am
some
I audible?
questions have been already addressed, and some are to be addressed. These include: does prucalopride has any food dependency like IBAT inhibitors, which are supposed to be taken 15 to 30 minutes before the meal? So this question is related to dosing. Does it have any food dependence?
Sir,
I mean, can I take the question
Was
if
I
I
audible?
understand?
the question, I think, prucalopride has any food dependency on a doses compared to...
Typically, you give before meal. You know why you give before meal? Because meal also stimulate HAPC or colonic contraction. So you want the patient to have the drug and then have the meal so that you taking the synergistic action of gastrocolic reflex along with the drug. Obviously, you are giving before because procalopride will take some time to start its action. And then you are giving the meal so that you get the gastrocolic reflex.
Yeah. Another 2 questions, Dr. Pradeep Gore.
Right, so noted, sir.
Hello.
Perfect, sir.
I'm from Jaipur.
Yeah, this is related to.
Hello.
Sir, this is related to is prucalopride safe in hepatic impairment? As some of the studies suggest, in hepatic impairment patients, ilobexabat increases the serum enzyme level and it has to be monitored. So, can prucalopride be a good option? Hepatic impairment, sir.
Yeah. Thank you so much, everyone. Since we have very less time.
Gerald, thank you so much. I
Hello.
think you had to sit for a long time.
Hello.
Thank you so much. It was really nice meeting you. And thanks everybody for their active participation. Good night to everyone.
Thank you.
Good night.
So there are two questions if you can add upon.
Hello, sir. Some question from Agartala. If you can attend, take sir.
Yeah.
Hello.
I-
So this is Dr. Meena. I'm speaking from the audience on behalf of audience from Agartala.
Since the speakers has
Already left.
All the doctors, I know the question, it will never end.
Okay.
I know it is too late. And
Thank you.
let me just first formally welcome Dr. Manish Paliwal, sir. I would request my colleague Kushagra just to welcome sir with the bouquet. And thank you, sir, for your quality of time
close
here.
the Zoom
I
meeting?
know it is very
Can we
difficult
close the
just to
Zoom
take
meeting, please?
all the answers from all the guests who are here. So just welcome, sir.
Can we close the Zoom meeting?